Dear friends and colleagues, welcome back to the Mangano Digital Academy and to the Essentials of Digital Dentistry. Let's again talk about combined computed tomography because it's a very important device for the acquisition of 3D data of the bone and teeth, hard tissues of our patients. And it is one of the most important devices in the whole workflow, in particular in the scan phase. Today we will talk about CBCT from another perspective that is much more clinical, and we will focus our attention on the patient positioning because it's a very important topic that sometimes is not considered enough, but there are studies that are emerging on this topic, and there are also different possibilities on the market with the different machine. So let's talk about once again the scan phases. Let's talk about combined computed tomography. As I told in the previous lecture, combined computed tomography is a game changer in the modern dental clinic. It's one of the door to the digital dentistry. It appeared in the late 90s and it revolutionized completely the way we acquire data from our patient, opening the door to the 3D world, to the third dimension. And it's not surprising that these machines now are spreading all around the world, and they are almost in all dental offices because they can change dramatically the way in which we make our diagnosis, and also we can in the way in which we plan the treatment of our patient. So what is the best patient positioning during the CBCT scan according to the literature, at least, and from the clinician perspective? From the clinician perspective, actually, CBCT units can be categorized according to the field of view, of course, the functionality, the detector type. All these characteristics are important, but the patient positioning also is quite important because the patient can stay supine, can sit, or we can have patient standing during the CT scan. So we have different options, obviously. And at the very beginning, with the first CBCT, usually the patient was in a supine reclined position because the first CBCTs, they look like the medical CTs at the beginning. So this is one example of one of the first CBCT available in North America 20 years ago. Now the things changed a little bit because we have more options, of course, and we can have the patient seated or standing. And it is interesting because the unit globally require less space and they are more accessible and also easier to use. This is the CS9600 from Carestream Dental. And this video show how it's easy today to have a comfortable and stable positioning of our patient. It's very important to avoid movement of the patient during the CT scan because the movement of the patient results in a motion artifact, and this can impair and can jeopardize our ability to make the proper diagnosis, for example, particularly in case of small structures, small endodontic lesions or periodontal lesion. And so it's important to have the patient comfortable and the patient doesn't have to move. And we have a lot of different options now with the modern CBCT. The patient can be standing but also sitting comfortably, and the devices are now much more accessible than in the past. And there is the possibility also to control very well the patient during the scan, the positioning, and to control if there is a movement during the scan. So this is a very important and very beneficial for our treatment. If we make an analysis of the literature, I found in this recent article that most of the CBCTs around that are available in the market, they have the patient standing, so in the position of the classic position of the panoramic radiograph. In 17% of the machine, there's the option of having the patient seated, and only in 8% of the machine we have the supine reclined position. So it's not so popular now compared to the beginning. The point is to avoid image artifacts. An image artifact is defined as a visualized structure in the reconstructed data that is not present in the object under investigation, so in real. Artifacts can be induced in several ways, and there are several kinds of artifacts. I will focus my attention only and mainly on motion artifacts, so in the importance of proper patient positioning and in the importance of avoiding movement of the patient during the scan, because all these artifacts are, of course, they can potentially jeopardize our diagnostic capability, but the motion artifacts are the worst, probably because they really can create a situation that make not possible for us to make the proper diagnosis, and particularly to proceed with some treatment, like for example guided implant surgery. When the patient is not correctly immobilized during the CBCT scan, so motion artifacts can occur. Patient movement usually presents itself as a stripe-like or ring-like pattern. So we can have double contour for the teeth, lack of sharpness, and clearly this can cause image blurring or an unclear margin of anatomical structure, and there is obviously a problem with landmark identification. That is a big issue for diagnosis, but also for treatment planning. As I told you, guided surgery is the most important application in this case that can suffer very much from motion artifacts. And this is an example of a motion artifact. When the patient is not correctly positioned, then it can move, and or she can move, and this is a problem because, as you can see, the overall quality of the radiograph can decrease. And I have considered some article in the literature about motion artifacts, and I found that the prevalence is quite high, even if the machine now are very, much easier to use, and they are more comfortable for the patient, and they have a lot of possible solutions. But anyway, there's a prevalence that is quite high, and the patient movement is a really big problem. And in this literature review, the authors found that particularly with young patients, so children, we can have a problem during the examination when there's the need to scan the children. And there is another study that I found very interesting. This one, the study compared by this group of researchers, compared the 3 different machines with the patient standing, sitting, or supine, and the occurrence of motion artifacts. And they found that there was no statistically significant difference between the different positions, but the authors found that the problem of motion artifacts can become worse with age, so for the older patients. So it's a conclusion that is quite different from the one of the previous systematic review. And these tables come from that article, and we can see that yes, there's a high occurrence and prevalence of motion artifacts. No differences between the different positions after all, but the author considered a lot of scan taken in a long period of time. But they found that also the age of the patient can be a factor in the movement, because they found that patients with more than 50 years, they had this problem more often than young patients, so from 18 to 49. So they didn't consider children, and this may explain the difference from the results of the previous systematic review. Obviously, landmark identification is very important in bone and maxillofacial surgery, and also in implant surgery, and particularly with some specific application like guided implant surgery, because we can have a problem. This article is also very interesting because they say that there's a particular problem considering the way the combined computed tomography usually work, particularly when there is an horizontal rotation of the head, and particularly left side rotation, which is the opposite direction to the scanner rotation usually, because this left side head rotation may influence the inconsistencies of projection data, more than the right side head rotation. This is interesting because, of course, with the modern machine we can control the patient and the fact that the patient should be immobilized during the whole scan, but of course we can consider that if we have this kind of movement we can even have worse errors. When we talk about guided implant surgery, of course we must be very careful because we are going to design and fabricate and use a surgical guide that is created obviously on a set of 3D images, and these three-dimensional images are images captured with the intraoral scanner, but also images captured from a CBCT because we need the data of the bone under the tissues. And we know that we have a problem in accuracy with guided surgery from a lot of different systematic and literature review. We can have deviation with the conventional guides that can be up than 1 millimeter, so 1.39 millimeter according to this work of Professor Tamaseb, as a deviation in the apex, 1 and 12 deviation in the shoulder, so quite important linear deviation and also important angular deviation among the planned position in the software and the actual position of the implant. So if there are deviations, there are errors during the workflow, and these errors can occur, of course, during the different phases. So during the scanning phase, the design of the guide, the fabrication of the guide, and then the surgery itself. And this graph to summarize a little bit the most important errors that can occur. And the first one is motion artifact with combined computed tomography. So if we have a motion artifacts in combined computed tomography, we should not proceed with guided implant surgery. So there are some systems, for example, this Twingis system, Twingis, that use a reference, and this reference, a Lego brick, is very useful to control not only the superimposition between the different scans, the scan of the model and the scanning during the CBCT, but also it's very useful to control if the patient has moved during the exam or not. So if the Lego brick is perfectly represented during the CBCT, because it's also radio packet, it's very precise, and we can superimpose to this Lego brick the original file, the design, the computer-assisted design of that Lego brick, then we can proceed with our surgery because we know that we didn't have any motion artifact and any distortion. But if the patient moved, we have motion artifacts, then we can control it. And if the Lego brick is totally, distorted, then we can't proceed with the planning. We need to be very careful because if we proceed, if we go on, we can make big mistakes after all during the surgery. I show you a simple case made on the concept of 2 appointments. So the first is combined computed tomography and intraoral scan, first appointment. Then we have all the plan. We can fabricate our surgical templates, the 3D printed model. We can check the accuracy and then we can proceed with surgery. And it's quite easy. So we use a CS3700 for the intraoral scan of the patient in this partially dentulous patient, very easy case. Then a combined computed tomography, and it's very important to avoid any possible motion artifact. So once again, the devices that are available now, they allow us to control the position of the patient, and it's very important. Then we can put together the information coming from the intraoral scanner with the information coming from the combined computed tomography with the merging, and then we can proceed with our implant planning. I think it's also very important to consider the merging of the file, because if the file don't merge perfectly, we need to consider, we should check this congruence among the information coming from the intraoral scanner and the information coming from combined computed tomography. We should check this congruence in all possible multiplanar reconstruction because it's another way to test and to check if we have or not, hopefully not, motion artifacts. Because if we have motion artifacts with combined computed tomography, probably the intraoral scan will not overlap perfectly. So it's another aspect that must be considered, not only of course the implant planning, the work according to the workup and the available bone, This is basically the diagnostic walks-in, the prosthetically guided implant placement. These are well-established concepts in terms of course, computer-guided surgery, computer-assisted surgery. In this case, I use this software SMOP that is very, interesting because it's parametric. And after the plan has been made, then you can export all the position. And what I do is basically I design my guide, in this case a set of hypno guides for the different drills, and I'm ready to proceed with the surgery. And these guides are the characteristic of being composed by a very simple structure connected with a cylinder, and this cylinder is absolutely the perfect way to guide the drill, because the cylinder has the perfect height for those specific drill and the perfect diameter. So there's no need to use long drills, there's no need to use stops, there's no need to use reducer for the diameter. Everything is customized, and these guides are, this is the sequence of guides for this very easy case, single implant. These guides are the hypno guide. They are laser sintered, one piece, and they are 4 sequential, absolutely identical in the shape, with the only difference of the hole of the diameter that needs to guide the drill. And the guided surgery proceeds very easy and fast with the surgeon that can. The surgeon can open the flap because the stabilization of the guide is given by the teeth, but at the same time by the bone, because that cylinder is exactly segmented over the bone. So once again, if we perform segmentation in SMOP, and it's possible, we can export the position of the bone. We need to be careful not to have any motion artifact, because otherwise probably our process of planning will fail. And this is how it works. It's only a computer-assisted procedure. It's absolutely easy. The preparation is performed through the guide, and then the position of the implant. If there's no need, like in this case of immediate loading, we can place the implant without any index or not through the guide. And this is the final result of the surgery. Very easy and fast. And obviously it's very important to be assisted during the positioning of the patient, because if we can check that no movement occurs during the exam, then we have a big advantage. And with the modern machine like the CS9600, it is possible to precisely position the patient inside the machine, and then to check during all the scan phase the immobilization of the patient. The patient doesn't have to move. And we have artificial intelligence tool that can help us, of course, like you can see here, to check that everything goes well and to obtain perfect images every single time. So the conclusions. During the beam computed tomography, despite of the position of the patient, we have different articles talking about the supine position, the patient sitting, the patient standing. But the point is that we absolutely need to minimize patient movements in order to avoid the occurrence of motion artifacts. Motion artifacts, in fact, can deeply affect and jeopardize our capability to make the proper diagnosis and then to plan our treatment well. For example, in guided implant surgery is very delicate. We need to avoid motion artifacts absolutely. And the modern computed tomography, they help us a lot, because they offer different valid and reliable solutions. For example, the CS9600, the patient can stand, or the patient, if the patient is old, for example, he can sit. And we know that the patient over 50 years old, from some literature studies, they more often move during the beam computed tomography, and the fact that they sit may help a little bit to avoid this, to reduce this risk and to avoid the occurrence of motion artifacts. So it's very important to obtain high quality images at first try, in order to not give another dose to the patient because we had some movement and some motion artifacts. This is key, particularly in surgery, but in all application of the beam computed tomography. So thank you very much for your attention, and don't forget, if you have some questions, some criticism, some comments, to write me. Here my email. Thank you.